firstly, I just would like to add my acknowledgement to country and just to note that Aboriginal people have been tremendous stewards of this land for more than 60,000 years, and that this year's NAIDOC theme of Heal Country is in so many ways relevant to what we'll be discussing this evening. Okay, so in terms of my presentation, there are three key messages. The first one is that I think that a lot of health professionals think that climate change might be important, but few realise how urgent and how serious it is as a health issue. Secondly, we'll be looking at our particular responsibility and indeed opportunity to act. And then lastly, about actioning our strategy. So I'll be providing an overview of what I see the key tasks ahead of the health system, and then just providing a series of snapshots and case studies and examples, really to stimulate discussions in the subsequent discussion groups. So climate change is a health issue. I'm actually going to start with the root cause of the problem, which of course is fossil fuels, okay? Particularly in view of this recent research, which was led by Harvard University, which looked for the first time specifically at air pollution caused by fossil fuels and the health impacts of that. And they found that fossil fuel air pollution is responsible for more than 8 million deaths each year. That is nearly 1 in 5 deaths globally. And if you want to put a face on those 8 million people, this is 9-year-old Ella. She is a little girl who lived in South London, in a very polluted part, congested part of South London. And she is the first person in the UK to have air pollution listed as a cause of death on her death certificate. The inquiry into her death found that air pollution, chiefly from traffic emissions, was a significant contributing factor to both the induction and the exacerbation of her asthma. And then we move to the other consequence of burning fossil fuels, which of course is climate change. And this article was written by a visiting American scientist actually last year. And Michael Mann makes the point that what we are experiencing is not normal. Half of the Great Barrier Reef now has been killed by underwater heat waves. We then had prolonged drought for years, and then unprecedented bushfire smoke from the Black Summer, which affected half of this country's population for weeks and in some cases for months. We regularly now have heat waves being broken, and if it's not heat waves, it's storms and floods. This is not normal. And this recent report, written by some of Australia's leading scientists, makes two really important points. The first one is about urgency. Climate change is not going to be a linear process. There are tipping points and feedback loops inherent in the Earth's ecosystems, and we are now dangerously close to hitting some of those tipping points. And there are now serious scientists contemplating the situation of a hothouse Earth, in which we hit tipping points and the Earth's temperature ratchets up to 5 or 6 degrees above pre-industrial temperatures. And in that situation, of course, much of the planet would not be habitable. The second point they make is that we've now left this so late, we have ignored scientists' warnings for decades, that the orderly transition that we wanted is not possible now, and to avoid catastrophic climate breakdown, we need to reduce our emissions by about 75% by 2030 and get to net zero by 2035. So 2050 is just way too late. So it's very hard to overstate the urgency of the situation. This is Sir David King. He's a former UK chief scientist, and he said recently, what we do in the next 4 to 5 years may well determine the future of humanity for thousands of years. This slide from the CDC sets out the diversity of climate health impacts. And of note, it's not just about extreme weather and air pollution, but also shifts in infectious diseases, food and water insecurity, mass human migration, conflict and violence. And these are the reasons that we're worried. Okay? And the WHO estimates that currently about 150,000 people a year are dying from these issues. Sadly, most of those are in the developing world, but of course, rich countries are not immune at all. And this recent report from the US looks at the health costs from climate change, from shifts in infectious diseases, from air pollution, from extreme weather, and calculates it at about $820 billion a year. And in Australia, we are one of the countries on the front lines of climate health impacts. From the Black Summer bushfire smoke, there were more than 400 deaths, more than 4,000 hospitalisations, and nearly $2 billion in healthcare costs. As you can see on the slide there were days last year in which Western Sydney was literally the hottest place on the planet. And now more recent research has shown that we've previously underestimated heat-related deaths, and that in a recent 12-year period, 36,000 Australian deaths were directly or indirectly related to extreme heat. And just as we see on a global scale, we know that these health impacts are not sort of fairly or proportionately distributed. It is the most vulnerable people in our community: children, the elderly, low socioeconomic groups, Aboriginal communities, the socially isolated people with disabilities. Those people are being hit the first and the hardest. And so this is an issue of health inequity and social justice. But the world is waking up to the climate crisis. And whilst we in the health profession have been pretty distracted over the past 18 months, there is now a huge amount happening at pace. There is literally trillions of dollars shifting away from fossil fuels. Many countries, including our major trading partners, have set net zero targets. And of course, US President Joe Biden has a very ambitious climate agenda. Disappointingly in Australia, despite the fact that we are one of the countries on the front lines of climate health impacts, we are one of the worst on climate action. We are one of the highest per capita polluters in the world. We're one of the biggest exporters of fossil fuels, and we're one of the few developed countries not to have set a net zero target. And in this recent report, Australia ranked out of nearly 200 UN countries, we ranked last in terms of climate action and progress towards sustainable development. And similarly, in the health sector, this is from the Global Climate and Health Alliance. This report card, again, assessed countries in terms of including health in their national climate commitments, and Australia was ranked equal last again. And so, pulling all of that together, if you think we have experienced disruption over the past 18 months or so, then it's really just a warm up for what is to come. Responsibility and opportunity. So what's the role of the health sector in all of this? Okay, so we have a big responsibility because one of the reasons is because we have a massive carbon footprint. Because we have a massive carbon footprint. Globally, if the health sector were a country, we would be the 5th biggest polluter on the planet. And this seminal paper in Australia was published a couple of years ago and measured for the first time the carbon footprint of the Australian health system. And the headline finding is that it's 7% of our national emissions. Well done to 60% of you got that right. 7% of our national emissions. That is the same as the total emissions of the state of South Australia. And this pie chart shows the breakdown of those emissions. And it's really interesting information here. So the first point is that if you add together public hospitals and private hospitals and capital expenditure, because a lot of capital expenditure is about hospitals, okay? And that altogether is about half of the footprint. The other part that's interesting is that dark green section, which is pharmaceuticals. So pharmaceuticals are nearly 20% of our carbon footprint. And then for us, it's also interesting to look at those orange and red wedges. So community and public health is only 6%, general practice only 4%. But I would make the comment that if you think about the role of general practice, for instance, they have, GPs have tremendous influence throughout the system in terms of prescribing, which affects the pharmaceutical footprint, and in terms of primary care and hospital admissions and referrals for investigations and procedures, which flows into the other aspects as well. So the key points here are that the health sector has a massive carbon footprint. About half of it is hospitals, nearly 20% is pharmaceuticals, and that primary care and GPs in particular have a significant influence throughout the system. Okay. And then this is data from the NHS. And this shows carbon hotspots by subsector. So if we look at primary care, that is the second column from the right. If you look down that column, you can see what the big spots mean a bigger carbon footprint, those areas. So in primary care, building energy is important. Metered dose inhalers are a big spot there. It's a big carbon hotspot in primary care, and we'll talk about that today. Medicines and equipment, medicines and chemicals, significant, the biggest carbon hotspot, and then non-medical equipment, business services, and then patient and visitor travel. Okay? This is really interesting information, I think, for primary care. And, you know, as people raised in the comments earlier, I've talked about carbon emissions, but it's just to make the point that the health sector has significant environmental impacts beyond carbon. Okay? You can see here significant impacts in terms of air pollution, in terms of plastic pollution, in terms of deforestation, and soil and water contamination. And biodiversity, of course, equally important. So these are equally important and often interconnected issues. And so overall, the irony is that the health sector, which is supposed to look after people, is in fact a major source of pollution. Carbon pollution, plastic pollution, air pollution, and these things are making people sick. And this is completely inconsistent with our core business, which is protecting and promoting health, and completely inconsistent with the values of many health professionals. On the flip side of that, if you have a big carbon footprint, it also means that by reducing it, you can have a big impact. Okay? And that more broadly, climate action would have so many benefits for health. It would mean cleaner air, healthier diets, greener and cooler cities, more connected communities, more jobs, and so on. So in so many cases, it is a win-win situation for health and for the environment. Okay, so what's the task? What do we need to do? As I said, there are two key tasks ahead of the health system. Okay? The first one is that we need to mitigate. Okay? Every sector is going to have to get to net zero. Energy, transport, education, housing, and the health sector, as we've seen, has a particular responsibility and indeed opportunity to do so. Now, what's called out in our strategy is that for primary care, we can have both a direct impact by reducing our own emissions, but we can also have an indirect impact by reducing reliance on hospital-based care. As we all know, that's something that we're doing for a bunch of reasons anyway, okay? Because the hospital sector is so carbon intensive and has such a big footprint. The second task is to adapt. Okay? And that's because even if we stopped polluting tomorrow, there is climate change locked into the system for decades to come. And so the health sector will have to be prepared and resilient for those changes. And you can see there in the diagram from the bottom, that's from DPI, a DPI publication. It shows, of course, there's overlap and interconnections between some parts of mitigation and adaptation. Okay, so if we start with sort of getting to net zero, the context is that whilst we nationally don't have a net zero target, every state and territory in the country does. They've all set a target of net zero by 2050. And indeed, as we know, some states are really forging ahead and really progressive in this area. For New South Wales government, the sort of 2030 target is a 35% reduction by then. And in the health sector more broadly, there are a number of calls from the Australian Medical Association, from DEA, from the MJA, sorry, the Medical Journal of Australia and others, for the health sector to be net zero by 2040. And that would bring us in line with what the NHS, National Health Service, target, net zero by 2040. But there are other examples, even in New South Wales. Hunter New England Local Health District, for instance, has set a target of net being carbon and waste neutral by 2030. Okay? And of course, as we've seen, evidence suggests we need to be making significant reductions by 2030 and net zero by 2035. So that's the sort of space, the context that we're working in. Okay, so how would we get to net zero? And what does that even look like? This is modelling from the NHS. I'm using the NHS because we haven't done anything like this yet in Australia. Okay? And you can see on the graph, on the x-axis is time, so it goes from 2008 up to 2050. And then on the y-axis, we've got carbon emissions in kilotons of CO2 equivalent, carbon dioxide equivalent. Now, the NHS first started on this project in 2008. They set up a national sustainability unit, which was tasked with decarbonising the NHS. That's where I previously worked. So they started in 2008, and over the past 10 years, they have been remarkably successful. They've reduced, despite an increase in healthcare activity, they've reduced their carbon footprint by about 20% and saved nearly £2 billion. They've now set themselves a target of net zero by 2040. And this modelling sets out how they could get there. So I'll talk you through this. You can see a whole bunch of coloured wedges. The top purple wedge is about decarbonising the grid. So that's obviously a national initiative sort of outside the NHS, but will impact on the NHS. Then the green sections are about digital care pathway redesign, low carbon models of care, and preventive medicine. About those things. The blue areas are specific clinical hotspots, carbon hotspots, anaesthetic gases, low carbon inhalers, and nitrous oxide. And the yellow section is about travel. So that's about reducing business travel, so not flying for conferences, zero emissions, ambulances, as we talked about, and active and public transport, travel related changes. And then the next two purple sections are sort of the engineering type stuff. So on-site renewables, smart metering, energy efficiency schemes, insulation, all those sorts of things come into the next two. And then the bottom wedge is about research, innovation, and offsetting. So there's a bit of scope there. So overall, the key message here is that there is no silver bullet. Getting to net zero is going to require changes at pretty much every area of the NHS. That's what we need to do. Okay, so this I think is a key slide from a health professional sort of point of view. This is from the Centre for Sustainable Healthcare in Oxford in the UK. And they've set out here their 4 principles for sustainable healthcare. I think this is a really useful way of thinking about sustainability. So the first principle is prevention. And that's because one type of carbon neutral health system would be a system in which we didn't have any patients. Everyone was healthy and well and independent in their homes. They were well connected in their communities. They were valued in their communities. They didn't need any healthcare. So that's prevention. We always need to keep that, I think, in the forefront of our minds. And also it's in recognition that so many of the things that so many of us do every day, they are actually sustainability measures. The second one is about patient self-care and empowering patients. And into this, I think, comes a lot of different sort of models, peer-to-peer models, social prescribing, improving social capital and networks in communities, connecting communities, asset-based approaches in which we use the intrinsic resources and skills of people to improve their health and to improve the community's health. So all of those sorts of ideas then come in with this second principle. Okay. The third principle is about lean service delivery. And essentially that's about reducing waste, including reducing clinical waste, which is low value care, and about different models of care and lean models of care. So telehealth is a good example. And then the fourth principle is to choose a low carbon alternative. And the point here is that, okay, where it is appropriate to provide care, how then do we choose the lowest carbon alternative? And so if you're going to choose the lowest carbon alternative, you need to know what the carbon footprint is. Okay? And that's why in the future, carbon will be as important as money. It is going to be like a whole new currency. And health professionals will need to understand, might not have to be experts in it, but they'll need to understand the basics about carbon accounting and what the carbon costs of different products, services and procedures and things are. Okay. And so we have a big task ahead of us to train up health professionals in carbon literacy. And indeed in the UK, they are starting to do that. And this I just put in to signal really the way things are headed. You can see in the ACT, they've done very well in terms of energy reform. They're now looking at their scope 3 emissions. So these are the embedded emissions in all their products and goods. Okay? And now they'll be looking at what the carbon costs of things are that come into the territory. Okay? So again, this is just a signal of the way things are starting to head. And I think this is an important slide as well, how we integrate, how we understand sustainability as part of quality improvement, and what is the appropriate now definition of value. Okay? So you can see that value is now, in this example, is regarded as being superior, better outcomes for patients and populations, while minimising the environmental and social and financial impacts, and the negative impact. Okay, so that's, I think, a good way of thinking about these sort of concepts. Actioning our strategy. So this is our strategy. As Kate mentioned, this was developed by a Climate and Health Steering Group last year in partnership with AHHA. And as Kate said, we believe we're the first PHN in the country to have such a strategy. The task now, of course, is to implement it. And that is why you're all here this evening. And what we'll be discussing in the breakout rooms. So there are 5 areas, as you can see there, in our strategy. And these will be the framework for discussions in the discussion groups. And I'll go through those at the end, just before we split to the breakout rooms. Okay, so this now is snapshots. So these are just, this is not covering everything. These are examples and case studies and stories, just to provide ideas really for your subsequent discussion groups. And I've tried to group them a little bit according to those principles, but of course there's a fair bit of overlap and interconnection. And this is the first example. I think someone might have been thinking of this in those questions. So this was an intervention by some GPs in Somerset in England. And basically it was a combination of care planning, social prescribing, community connectors and link workers, and compassionate communities. And the outcome of this was a 14% reduction in unplanned hospital admissions, whereas elsewhere in the county it was a 30% increase. Okay? And they also, in this intervention, saved about 20% cost-wise. So my point here is that this is not only delivering health and social outcomes, but also intertwined with that is the environmental benefits as well, both in improving the connectedness and the capacity of the community, and also in reducing reliance on the hospital care. And this is just a nice slide to provide an overview, I think, from a primary care perspective of the health and environmental benefits. So you can see there it basically focuses on clean energy, clean transport, active transport, and plant-based diets, and then the list of sort of related health benefits from all those things. And if we drill down now into a specific example, the planetary health diet, this is from the EAT Lancet Commission. And basically it's saying that it found that a plant-rich diet, planetary health diet, which is plant-rich, has significant benefits both for health and for the environment. And then in activity, I mean, if exercise were a pill, it would be a miracle cure. And there is so much good evidence now that people who are more physically active have significantly lower rates of everything from cognitive decline to mental health disorders to some cancers. Okay? So this is a low-cost, effective, low-carbon medical intervention as such. And that's why we should be promoting, I think, and supporting from a health and an environmental perspective these sorts of schemes. This is a bike riding scheme to encourage active transport, encourage our staff to commute by bike to work. So these sorts of things need to have that health and environment lens over them. And trees. Trees have a whole range of health benefits. They provide shade, so they reduce UV exposure, they have a significant cooling effect, they improve air quality, they provide space for activity and social interaction, they have mental health benefits, the whole lot. And also, importantly, given that extreme heat is probably the #1 climate health risk for many urban populations, trees and tree canopy will be an important adaptation measure as well. So again, the health and environmental lens over these sorts of initiatives. This was Plant With Us from Randwick City Council. And this example, this was a project team that teamed up with some general practices in East Oxford. and they developed a series of resources, these maps, posters, prescription pads, which GPs could prescribe these walking routes. So a way for people to connect with nature and get physical activity in their local neighbourhoods. And this is an example from Adelaide, a nature prescription trial. This is run by a group of GPs, psychologists and allied health staff. They've got 60 participants in this trial. The intervention is for 8 weeks, and they'll be following them up in terms of mental and physical outcomes. And this is actually an example of a hospital. It's Alder Hay in the Park. It's a children's hospital in Liverpool in England. And you can see, watch closely here, because you can see there the hospital in the middle with the car park sort of below and to the left. Okay? And then they built a new hospital, and this hospital was basically designed by kids. And then this is what they did. So clearly this is the way that we need to go in the future. And what a fantastic also community space there right in the middle of the community, that park and the green space for children and for everyone. And then this research from recent research quite close to home, finding that people's odds of loneliness could fall by up to half if cities hit a 30% green space target. So just bringing together connected communities, reducing loneliness, and we know that loneliness has a whole range of deleterious health impacts, and green space, to bring that all together for a range of benefits. Okay, lean service delivery. So as you would know, there's growing concern about too much medicine, and that there are significant harms and risks and costs to patients and to the system of overdiagnosis and overtreatment. And the costs are not just financial costs, but also environmental costs. Okay? So just the point here that reducing low value care, that is care in which the risks and costs outweigh benefits, reducing low value care is an important principle in sustainable healthcare. And this is just one example. This is from some colleagues at the University of Sydney. They found about vitamin D testing. They found that last year, MBS funded about 4.5 million tests, vitamin D tests. That is about 1 in 5 adults being tested for vitamin D in Australia. That increased from the previous year. From the literature review, they'd found that 75 to 90% of vitamin D tests were unnecessary. That overall, that's about 3 to 4 million unnecessary tests last year, about $100 million in Medicare costs, and a carbon footprint of about 50,000 tonnes of CO2 equivalent. Okay? So again, just making that point. This was a course recently that I attended about sustainable primary care. This was run by GPs and for GPs. So I was a bit of an imposter on the course, but it was really interesting. And they were saying, okay, further to what someone asked earlier, where do we start in primary care? What are the hotspots? The number one there was prescribing. And you can see there on the table that they've calculated that a GP appointment, including prescribing, is about 66 tonnes of CO2e. They made the point that many GPs are well aware of the harms of overprescribing, the risk of side effects, of drug interactions, of polypharmacy, particularly in the elderly, and a lot of GPs are working on deprescribing and optimising medication use, but that the carbon costs, the environmental impacts might be an additional frame or way to look at this. This is one example from a GP. She just described what she was doing in her practice around polypharmacy. She had started to pull out all of her patients who are on more than 10 medications and was looking specifically at them. She was also working with her colleagues to raise awareness. Very much her focus was on patient safety. She said, first and foremost, that is our key reason. Environmental impacts is another consideration. She talked about they were implementing annual medication reviews together with their practice pharmacist and the non-pharmacological treatments which we've talked about. This is an example on telehealth. This is from the Royal Children's Hospital in Melbourne. In one financial year, they did more than 2,000 consultations. They saved 1.3 million kilometres and about 58 tonnes of CO2e, carbon dioxide equivalent. So that was in 2017 to 18. So you can imagine what the sort of figures and what the sort of numbers would have been last year there and everywhere else. I just wanted to include one slide on energy, because obviously that's one thing that practices can do immediately, can switch to green energy to reduce their footprint. And then also consider solar panels and batteries and things. This is Riverstone Family Medical Centre in Western Sydney. They have a range of initiatives that they've taken. And then finally on low carbon alternatives. So as we said, if you're going to choose the low carbon alternatives, you need to know firstly what the carbon costs are. This was a paper published last year in the MJA, Medical Journal of Australia, which looked at the carbon costs of the 5 most common hospital pathology tests. And we're now working with some of these same colleagues on the carbon costs of imaging. So what are the carbon costs of X-rays and CT scans and MRIs and things? But just to make the point, there is a growing and rapidly growing body of literature now on the carbon costs of everything in medicine, from cataract surgery to childbirth to reflux treatment to different surgical approaches. Okay? And in primary care, and someone that's mentioned, the biggest carbon hotspot so far that was perhaps unexpected, I think until the research was done, was MDIs, so metered dose inhalers. Metered dose inhalers are in the NHS about 5% of the whole of the NHS's carbon footprint. And that's because the hydrofluorocarbons, which are used as the propellants in MDIs, are potent greenhouse gases. There are lower carbon alternatives. You can see that the dry powder inhalers have a fraction of the environmental impact. They're not appropriate for all patients. And this is just an example. This was a quality improvement project that was undertaken at a general practice in Glasgow. They looked at the inhalers, they talked, they surveyed sort of staff and also a number of their patients, a number of questions around these sort of issues. And these are the sort of findings broadly that they came up with. The first step always is care optimization, common sense approach, and then about inhaler efficiency. So you can see there that because it's the propellant, that's the problem. If you can minimize the number of doses, that can be beneficial. Inhaler switching, if and as appropriate. And then they also talked about, obviously, inhaler disposal and how that can be appropriately and more safely disposed of. So I think this, certainly if we're going to do bang for our buck sort of projects in primary care, we should be looking at respiratory inhalers. And some research underway by Monash University. Obviously, the pharmaceutical industry is seeing the way things are heading and is interested in lower carbon inhalers as well. Just a couple of notes about waste. The important thing about waste is to think about the waste hierarchy, okay? And that is reduce, then reuse, then recycle, in that order. So we can kill ourselves trying to recycle things, but really if you want to cut to the chase, we've got to focus first and foremost on reduce. And that's not producing waste in the first place if we can. This is just one example. This is from some ophthalmologists at Sydney Eye Hospital. This is their intravitreal injection packs. They noticed that they were throwing out 80% of these packs because they were custom packs and there was a lot of excess stuff in there. So they're now redesigning those packs so they'll just have the items that they absolutely need in them. So I think that's just an important principle to think about. How can we really have the most impact in what we spend our time on? And then clearly we should be shifting towards zero waste in our office and non-clinical areas. Then reuse and recycle. This is an example of blister pack recycling with TerraCycle in the UK. This is the general practice in the UK. Clearly, we need to be shifting towards a circular economy. Okay, so where we do need to use products, how then can we capture those and reuse them, make them into new products? This is needle caps and saline and water ampules at St Vincent's Hospital, which are then remade into chiefly building materials, including these roller doors. So these are the sorts of things we need to think about. I just wanted to make a point about the mental health side of things because that is critical. We are seeing now growing rates of eco-anxiety, anxiety and depression, particularly in young people, and also, of course, the mental health impacts of extreme weather events, and often those are long-term. And just a couple of notes about heat, because a lot of the things that I've talked in terms of adaptation and resilience, I've touched on a lot of the things that are relevant to this, green space and cooling, connected communities. All of these will be really important in terms of resilient communities and climate adaptation. But heat will be is the number one climate health risk for many urban populations in Australia. And primary care and health professionals are going to need to be really strongly involved in this. There are a number of solutions they're talking about: greening cities, tree canopy, obviously, building design, so building up and down, underground, rather than urban sprawl, reflective paint on roads, retrofitting, more secure on-site energy and air conditioning and so on. But for our vulnerable populations who are most at risk, they're now talking about having things like heat refuges. So these are community spaces which people can go to that are air conditioned, that could be safe during the day. So just a particular focus perhaps in your discussions to think about heat. Resources, I'm just going to whiz through this section just to give you a sort of an idea of the sorts of resources that are available. And indeed, if there's interest, we could compile these and provide them for you. These are all things that either I've done or have been recommended to me by primary care colleagues. Just to note, the North Sydney Planetary Health framework, it's really, really terrific framework, and a Planetary Health Committee. I've been invited as SNHN rep to be on that committee, and indeed we have a number of North Sydney colleagues on this call today. So we really look forward to working together in partnership on this issue. I think it's a really, really useful to have primary and tertiary care both involved on the same page on this. There are a number of papers and articles around about, top tips for general practice, the 6 steps to greener and better primary care. Similarly, this in the MJA that we can, put in some sort of resource pack. Some great webinars around this one by the Primary Health Alliance in WA. Reducing our impact in general practice, what can we do? DEA, Doctors for the Environment Australia, has a great series of webinars that are freely available to anyone. There's a lot of useful toolkits around. This one from the College of GPs in New Zealand. Similarly, our College of General Practice has a specific interest group in this, and also has some toolkits and fact sheets. This in the UK is a sort of one badged as being the one-stop shop for greener practice. And this site similarly was recommended to me by some GP colleagues. I did this course recently, Centre for Sustainable Healthcare, and indeed we're thinking if there's interest, we could get together a group of people to do this course. The UK times can be pretty tricky to adhere to, so if we had enough people here, we could get a more Sydney-friendly time zone, which would be good. Our colleagues at DPI have recently released this terrific climate risk ready guide, which is about how you incorporate climate risk into your existing structures and processes. And there's also courses. This one, Western Sydney University in partnership with DPI, about climate risk ready for chiefly for sort of public sector, and Climate and Health Alliance and GGHH. So just in finishing up, I just wanted to note this recent, some of you may have seen this in the papers, this was the ruling on the Sharma case, in which it was found that the Environment Minister has a duty of care to protect us and children and young people in particular from carbon emissions. And the judge, in handing down his finding, noted the health impacts, the evidence was given about the health impacts. And he made this comment that none of this will be the fault of nature itself. So the health impacts aren't the fault of nature itself. It will largely be inflicted by the inaction of this generation of adults in what might fairly be described as the greatest intergenerational injustice ever inflicted by one generation of humans upon the next. So this is my final slide. I'll get to the question. This is from Ipsos Mori. Ipsos Mori is a social research institute in the UK, and every year they rank from the most trusted at the top down to the least trusted professional group in society. Okay, so you can see that doctors do pretty well, but nurses are the winners, 93%. So health professionals are the most trusted and respected professional group in society. Okay? And primary care providers in particular are well influential with patients and in their communities, and indeed with professional groups and in the media as well. They're well integrated in their neighbourhoods. They are in many cases small business owners or employees. They are exemplars. Primary care practitioners are probably the most trusted professional group in the whole of society. The climate crisis threatens the health and indeed the safety of our patients, of our communities, and indeed our own families. And this is happening on our watch. And so many people ask me, okay, what can I do? The answer is do something. Okay? Get up tomorrow, do something. Get up on Friday, do something. Get up on Saturday, you give yourself the day off. Get up on Sunday again, you do 2 things. Because I can tell you that action feels much better than anxiety. The world is about to change very quickly, and we are going to need all hands on deck. Thank you.